Welcome, everyone. Welcome to the Zoom meeting. Today, Dr. Samira and her team will be presenting. So I'm going to hand it over to Dr. Samira when you are ready.
Okay, thank you, Dr. Nader. Hello, everyone. Hello, fellows who is attending today's meeting. My name is Dr. Samira Mohammed. I am Page 1 team leader. Today, our team will be presenting 6 topics. Hopefully, you will have it very informative. Thank you for all who is watching us. Our first presentation will be with the hematology in older adult, will be presented by Dr. Yousif and Dr. Abdallah. The second topic will be to talk how to develop a quality research article and avoid journal desk rejection by Dr. Omer. And we will talk then about a brief introduction to secondary data analysis by Dr. Mohammed. And our fourth agenda will be the role of acute care prescribing in opioid epidemic. Will be presented by Dr. Mohammed and Dr. Tahir. Five on the agenda will be talking about depression, will be presented by Dr. Gargum. And last topic will be about Google interview warm-up by Dr. Mutwali. Thank you all for the fellows who's going to be presenting today, our team and other fellows from other teams. Dr. Marwa Yousif and Dr. Eiman, if you are ready, please share your screen and start your topic. Dr. Eiman?
Yes.
Yes. Whenever you are ready, feel free to share your screen.
Okay. Dr. Marwa, are you ready?
Yes, I'm ready, but I cannot yet share my screen. Can you hear me?
Okay,
Yes.
let me check.
Hello.
Hello.
Yes.
Okay.
I'm still not able to share.
Can you, Dr. Nader, would you mind if make them a host?
I can share my screen, but I think the problem from Dr. Marwa.
I cannot still share my screen. I don't know this. It's giving me an error.
Dr. Eiman, maybe you can share, and then Dr. Marwa can present, and you can present whoever present first, and then followed by the second. But Dr. Eiman, you can share your screen if you can.
Okay, I can share my screen. I can present first.
Yeah, go ahead.
It's okay. It's fine by me.
Okay.
Whatever easier for you guys.
Okay.
If you cannot, I could share my screen.
Is that okay for you, Marwa?
Yeah, absolutely.
Okay, go ahead.
Okay. Okay, try again, Marwa. I have updated. Try again,
Okay.
sorry.
Is it appearing or not yet?
I do not see it.
Okay.
It's
giving me an error. I don't know why.
even mine. I
Can I send you the document, the presentation, and you present it by your screen?
I cannot share it. I was able to share, but now I cannot share it. Okay, yes. Okay.
Yes. Thank you so much.
Okay. Sure.
If it's possible to put it in presentation mode.
Okay.
Okay, thank you so much, Dr. Samira. Hello, everyone. Can everyone hear me? Can you all hear me?
Yes.
And if there's any problem in the presentation, can you please tell me before I start?
Yeah, I
Okay.
can hear you.
Okay. Today we have the topic of hematology of older adults. My name is Dr. Marwa Yousif. I'm a fellow in the team page. I'm going to present this first part, and my fellow Dr. Eiman will present the rest of the topic. Let me move to the second slide. Yes. For the objectives of this presentation, we will discuss an introduction of disorders of hematology in older adults. We will have an overview of anemia of older adults with a definition, epidemiology, and etiology. We will discuss the clinical feature of anemia in older adults and the important investigation. We'll have an approach for management of anemia. We will also cover the white blood cell disorder in elderly with their different etiologies. We will discuss the clinical presentation of leukemias and lymphomas in elderly and how to manage each one of them. Next slide, please. So, aging is associated with a variety of biological processes that might lead to development of diseases or that represent the consequence of chronic illness. Management of hematological disorder in older patients must often be weighted in the setting of decreased physiological reverse and the concurrent illnesses. Next slide, please. So we have anemias. For anemia, we start with a definition of anemias and epidemiologies. For anemia, we will take the definition from the WHO in the 2024 update. They have defined anemia as a certain cutoff point based on gender and age. We should adhere to the cutoff point, but this cutoff point should not precede our clinical judgment. So for older adults in the population of older adults, we generally use the cutoff point of 11.5 gram per deciliter for hemoglobin or hematocrit of less than 35%. This is for females, and for males, we have a cutoff point of 13.5 gram per deciliter for hemoglobin and a hematocrit of less than 40%. Next slide. Among older adults, anemia is common. It affects 12% of persons above the age of 65 years of age who are living in community. But the prevalence of anemia rises up to 47% in persons who are living in nursing homes and up to 40% in patients who are admitted in hospitals. For the etiologies of anemia, frequently the anemia's etiologies is multifactorial in older adults. Although for major causes of anemia, there is approximately 30% of anemia due to nutritional deficiency. Another third is due to chronic diseases or chronic inflammations. And there is a third of cases which we call it unexplained anemia of aging. In more depth, the hallmarks of aging are hematopoietic stem cells exhaustion and cellular senescence, and a dysregulation of nutrition and sensing. For older adults, are more likely to develop gastrointestinal disorder leading to blood losses like diverticular disease, and they can also develop malabsorptions that were compound with anticoagulant and antiplatelet disease, antiplatelet agent, um, can lead to further acceleration of anemia development and with association with the decline of nutritional intake. Ferritin level usually increase with age, and patients with conditions such as chronic heart disease and chronic inflammation disorders may experience iron deficiency with a high level of ferritin up to 100 microgram per deciliter, and as high as also 300 microgram per deciliter. So we can refer to the transferrin saturation in such cases which it's less than 20%, then we can define the patient as having iron deficiency anemia. Folate is uncommon cause of nutrition deficiency in this group of population, but it can be seen with excessive alcohol use and poor nutritional intake. Next slide. Older adults are more susceptible for chronic inflammation, which can be related to established comorbidities such as rheumatoid arthritis and advanced cancer, or from aging itself. This inflammatory response will lead to dysregulation in iron metabolism and will lead to blunted hematological response in erythropoietin. As for erythropoietin, which is considered a crucial factor in RBC productions, its level in older adults is influenced by decline in multiple factors, which include aging, which cause nephron size to decrease, and the number of nephrons decrease, which lead to decreased level of erythropoietin. And for chronic kidney disease patient would decrease the production, obviously, of erythropoietin by nephrons. Testosterone also declines level of erythropoiesis by a negative feedback. Next slide. As we mentioned previously, 1/3 of anemia of older adults caused by unexplained anemia of Asian, which is a diagnosis of exclusion. The pathogenesis is unclear behind it, and it's possibly related by multiple age-related changes. There is an overlap exists between unexplained anemia of Asian and idiopathic cytopenia of indeterminate significance. For anemia, unexplained anemia of Asian is diagnosed, as I mentioned previously, with exclusion. It may only in older adults, where we can see a mild anemia. Often the hemoglobin will be less than 2 grams per deciliter below the lower limits of normal. There won't be any cytopenia and no other causes to explain the anemia. And if we tested the blood or the bone marrow, we won't see any dysbiosis or hematological malignancy. Whereas for idiopathic cytopenia of indeterminate significance, which can be diagnosed by any age with one or more cytopenia or colonal hematopoiesis with a variant allele frequency of less than 2%. Next slide, we will discuss more the colonic hematopoiesis. The colonic hematopoiesis refers to population of blood or bone marrow cells of a myeloid lineage that share acquired or genetic mutation. For chronic hematopoiesis is a characteristic of hematological malignancy, such as myelodysplastic syndrome, myeloproliferative neoplasm, and acute myeloid leukemia. Unexplained cytopenia is referred to a condition characterized by peripheral blood cytopenia, whose origin is not attributed to cause detected with conventional testing due to concomitant disease or due to concomitant diseases. For peripheral cytopenias are usually common in adults, especially in older adults, and can either be sequential or it can be signs of serious disease. As we see here in this photo, there is an overlap between the anemia of unexplained anemia of Asian and idiopathic cytopenia of undetermined significance. We have also a common shared feature between colonic cytopenia of undetermined significance and idiopathic cytopenia of undetermined significance. As both of them, they do not meet the criteria of myelodysplastic syndrome and have less than 10% dysplasia, and there is no increase in blast cells, both of them, where there is a common shared feature between colonic cytopenia of undetermined significance and myelodysplastic syndrome with one or more shared related mutation of myelodysplastic syndrome in both of them. There is a features of myelodysplastic syndrome where we have more than 10% of this dysplastic cells or more than 15 fringe sideroblastic or 2 to 19% circulating myeloblast. And we have chromosomal abnormality defining the myelodysplastic syndrome. Next slide. We will now see the clinical feature of anemias in older adults and how to investigate it in a proper manner. Next slide. The cardinal signs of anemia is, and for anemia's signs and symptoms is resulting from impaired oxygen delivery. In older adults, mild anemia has been associated with poor physical performance, lower muscle strength, depression, and more severe anemia causes increased mortality, increased risk of fall and hospitalization, and decline in activity daily living activities, and decreases the quality of life of this population. Even in high functioning adults, anemia is associated with fourfold increase in risk of impaired executive function. Next slide. We usually start investigating anemia with the use of CBCs and RBCs emphasis and WBCs differential. The following testing is initial for evaluating anemia. We have the reticulocyte count, which reflects the ability of bone marrow to produce RBCs and can be used as to categorize possible causes of anemia. We can also order a chemistry panel would include assessment of kidney and liver function with creatine, ALT, and AST level. There is also labs, hemolysis lab, which include LDH, bilirubin, hemoglobin, and in history suggestive of more hematologic hemolysis of anemia. We can also order blood smear, which will have will give us a good idea about which type of anemia we are dealing with. Next slide. Routine testing we have a set of routine testing for older adult above the age of 60. We should do kidney function. Yes, we can do kidney function. We can do the estimated GFR. If the GFR less than 45, and there is absence of other diagnosis, so we can go as CKD as a cause for this type of anemia. There's also iron studies. We can order it, vitamin B12 level and methylmalonic acid. And we can also order folate level in cases of malnutrition. Next slide. Also, we can order more of imaging and more intervention testing, like ultrasounds, giant X-rays, CT, endoscopies, either upper and lower, and even capsule endoscopy for area we cannot access, like small bowels. Next slide. There is additional test, but we should order it only in certain, if we have a high suspicious of certain diseases. Like, for example, we have monoclonal gammopathies, when we have a higher suspicions of, for example, multiple myeloma associated anemia, where we can order when there is hypercalcemia, when there is an increased level of serum free light chains and serum protein electrophoresis. There's also androgen testing, which in other adult, as I mentioned previously, the androgen, the testosterone level can affect the erythropoietin and will lead to normocytic anemia. There's also myelodysplastic and colonal cytopenia testing, and we can do it in signs. Can do bone examination for signs of dysplasia. If we have the diagnosis of myelodysplastic syndrome in mind, for adults with a stable and mild normocytic anemia and other cytopenias with or there is evidence for evidence of dysplasia on the near some expert, they can just order CBC and will not perform the bone marrow. Next slide. So we have case here. This is the case of a 75-year-old woman with stage 3 chronic CKD. She had a previous history of gastric bypass 20 years ago, and she's non-hyperlipidemic and had rheumatoid arthritis, which she take photos of prednisolone daily. She was referred for evaluation of anemia. Her weight in the clinic was 46 kg. She has been on compound multivitamins and B12 injection from her pediatric team. She reported severe fatigue and feeling winded with prolonged walk-in. She denied hematochezia or melena. For her lab, WBC shows 8.7, hemoglobin is 8.4, MCV is 101, platelet 204, retic count is 53.9. Creatinine is 2.4. Estimated GFR is 20 mil. B12 is more than 1500. Ferritin is at 50. And iron 76. Total binding capacity is 383. And transferrin saturation is 20%. Folate at 9.4. TSH 2.4, and copper at 134. Next slide. So they did a peripheral blood smear and shows macrocytosis. After initial workup, additional laboratory testing revealed CRP of 22.5, erythropoietin level of 24. There is no spikes. There's no M spikes on serum protein electrophoresis. Focal blood test was negative. Lactic dehydrogenase is 200.2, 202. They did also colonoscopy for her, which shows non-bleeding internal hemorrhoids. Her endoscopic EGD was normal with no H. pylori. They also did bone marrow biopsy and aspirate with myeloid sequencing, fish and chromosomes which show normal cellular bone marrow at 20 to 30%. And there is no dysbiosis and no abnormal karyotyping. So in this case, what could be the cause of heart anemia? We can return to the previous slide, if possible, the previous slide, not the next slide. So we can answer it in the chat if it's possible. We can give people time to discuss it. Okay. Have one answer of anemia of chronic disease with iron deficiency. Okay.
It could be anemia due to the MCV is a bit high, but she has chronic kidney disease, so maybe due to lack of erythropoietin.
Okay, it could be so due to the lack of erythropoietin and also to macrocytosis, as you mentioned, for lack of absorption. What could be else?
Folate deficiency.
Folate deficiency. Very interesting. Yes, the level of folate is low, normal level. What else? Okay, we can go to the answer now. Next slide. So basically, this is a multifocal anemia. It's a multifactorial anemia which is the common finding in older adults. There is iron-restricted erythropoiesis from malabsorption because you already have a bariatric procedure. Also, we have anemia of chronic kidney disease, as we saw the GFR. This patient is around 20, I think. And there's also anemia of chronic inflammation, which she have already rheumatoid arthritis and CKD. So all of you were right. So this is a multifactorial anemia, and we should manage her in a stepwise manner. Next slide. So how do we approach anemia management in elderly? So as I mentioned, it's often multifactorial and should be evaluated and managed in a sequential manner. For nutrition deficiency should be always corrected and maintained with a special corrected with a special attention of iron, adequate iron stores, especially in patients who are taking erythropoiesis mediating agent for example, anemia of unexplained anemia of aging. Also, management of anemia in iron deficiency anemia in older adults. We can use oral iron supplement, which contain 50 to 65% milligram of iron. We don't go toward the IV iron unless or iron is intolerable by the patient or there is malabsorption of iron. For all the other with mild B12 deficiency and with normal absorption, usually they respond to oral dose of B12 with 1,000 micrograms daily. With patients with impaired absorption, we can give them parenteral B12. For folate deficiency, we typically give them 1 to 5 milligrams daily. And this dose is high and sufficient even in patients who have malabsorption of folate. Because there is an excess of 200 microgram from the usual level, like it will overcome the malabsorption. For anemia of chronic diseases, we of course we have to treat the underlying chronic inflammation process to treat the anemia itself. Next slide. So this is an evaluation and summary of the management for anemia of older adults. We have the anemia itself of a level of less than 12 in females and less than 13 in male. We will go for history and examination and physical examination for standard anemia. We should treat the treatable condition, which is on the right side, iron deficiency, folate, B12, thyroid. If still anemia is resisting, it's not easily treatable, we go for evaluation for other causes, which include inflammatory, CKDs, and we will go to exclude other causes in this, like preferred smears. If there is a red flag in the history, we can do bone marrow biopsies, and we can refer this patient to hematological in this case. Next slide. we have the criteria for referral. So when we do refer the patient for hematology, we have situations that we have to refer a patient for hematologies, which are hematological emergency, like severe pancytopenia, blast or immature myeloid and lymphoid formed, pancytopenia with hemolysis, thrombosis, or bleeding, and macroangiopathic hemolytic anemia with schistocyte on both smears. So right now we are in the middle of our presentation, and we will go to discussing disorder of blood cells in elderly, white blood cells in elderly patients. Okay. Before we start, there is an important clinical key point we have to put in mind. Aging is not associated with change of WBC counts, so elevation or depression of WBC should be evaluated as possible illness. The drugs and infections are common causes of both increase and decrease of WBC count and should be considered when evaluating new onset of leukopenia and leukocytosis in senior adults. Disease characteristics alone do not fully explain age-related disparity in even among older adults with favorable disease biology. Outcome remain worse than younger adults due to increased comorbidity, age-associated physiological changes, the use of polypharmacy, and functional and cognitive impairment would complicate therapies in older adults and likely to contribute to decreased treatment tolerance and shorter survival. CLL is the most common leukemias in the Western Hemisphere and might be expected to be encountered in geriatric practice. The median age of diagnosis is approximately 70 years of age. Next slide. Older adults makes up a large population of incident and prevalent causes of malignancy at WPC, as well as those dying from these conditions. In 2019, there were around 644,000 new cases of leukemia around the globe. The surveillance epidemiology and end result program estimate that will be 59,000 new cases of leukemias in 2023 in the US, representing 3% of all new cases of new cases of cancer. For CLL, which is the most common cause of leukemia in the Western world, in the US, around 67% of diagnoses occur in people aged more than 65 years. The median diagnosis is 70 years. CLL is the most common in men, more than women, with 6.4 new cases versus 3.4 new cases in women in per 100,000 case. For MO, in 2024, there will be estimated of 20,000 new cases and 11,000 deaths related to AML in the US. AML are more common in older adults. In the US, approximately 61% of cases are diagnosed of the age of 65 and over. The median age of diagnosis is 69 years of age in the US, and it's also more common in men than female with a ratio of 1.5 to 1 in the US. And for CML, in the US, it has been estimated that in 2023 there will be 1,009. Oh no, the previous one. Yes. There will be 8,900 new cases of CML and 1,300 deaths. CML will account for around 15% of all new cases in leukemia in the US. In the US, the incidence is between the age of 65 and 74 years of age, but it can affect all ages. The median age for diagnosis of CML is 66. It's also more in the female with 2.5 versus 1.5 in female. ALL is actually rare in older adults. The estimated new cases is 6,500 new cases, and the death is around 1,300. The median age for diagnosis is 17 in the US. Next slide. We won't be discussing ALL in this presentation in more depth, but we will discuss both CML, AL, CLL, CML, and AML. For lymphomas, in 2023, it's estimated there will be approximately 80,000 new cases of non-Hodgkin lymphoma in the US and 20,000 non-Hodgkin lymphoma related deaths. Non-Hodgkin lymphoma is uncommon before the age of 50, but the incidence increased with age. Median age for diagnosis is 68 years. First degree relative with non-Hodgkin lymphoma are approximately 1.7 times increased risk of developing non-Hodgkin lymphoma, and it's also more male with than female, with 22 new cases versus 15.5 new cases per 100,000. It's estimated for Hodgkin lymphoma, it's estimated that 8,500 new cases of Hodgkin lymphoma, and it's associated with 900 deaths by the year 2024 in the US. The median age for diagnosis of Hodgkin lymphoma is 39 years of old, with a peak incidence occurs between 20 and 35 years old. Data indicated a bimodal distribution of age at diagnosis, which peak between 15 and 35 years, followed by a more modest peak at the age of more than 25 years. It estimated that for multiple myeloma, it estimated that there will be 35,700 new cases in the US by the year 2024, and it will be associated with 12,000.5 deaths. The median age for diagnosis of multiple myeloma is 69. Incidence of multiple myeloma in the US also is higher in male than female, with 8.7 versus 5.9 per 100,000. I just want to apologize to everyone for these amounts of numbers, but I think they are crucial for this presentation. Let's talk about the etiologies. For leukemia, leukemia defined as malignant proliferation of hematopoietic cells. It categorized based on the cellular origin as myeloid or lymphoid and on the level of differentiation. We have acute leukemias, which show proliferation of minimal differentiated cells, such as myeloblasts and lymphoblast, and defined as more than 20% of blasts in bone marrow, where we have less than 20%, as is defined as myelodysplastic syndrome. For chronic leukemia, proliferation of more mature differentiated cells, such as the myeloblasts, metamyelocytes, myelocytes, and lymphocytes. And for lymphomas, result from monoclonal proliferation of cells of lymphocyte lineage. Approximately 90% of them are derivative from B cells, and 9% from T cells, whereas 1% is from monocytes and natural killer cells. For Hodgkin lymphoma, it's a malignancy of Reed's cerebral cells, which are B cells origin. We have Epstein-Barr viruses playing a crucial role in the pathogenesis of this disease, and usually it occurs in younger adults. For non-Hodgkin lymphoma, they are a group of heterogeneous malignancies of lymphoid system. This heterogeneity is around 30, more than 30 entities. They stem from a function of the lymphoid arm of the immune system, which imply various types of lymphocytes to defend against diseases. There are lymphoid malignancy can be originated from both T progenitors, mature T cells, T cell progenitor, mature T cells, natural killer cells. For multiple myeloma is a malignancy of neoplasm of plasma cells. Myeloma cells proliferate and accumulate in bone marrow and secrete abnormal monoclonal immunoglobulins or immunoglobulin fragment, which also known as paraproteins and M protein. So for clinical presentation for leukemias in elderly and lymphomas in elderly, next slide. We will see that they have a similar presentation, most of them, but we will discuss each one of leukemias and lymphoma and the features that they can present in. For AML, patient will present with fatigue, bruising, anemia, fever, and leukemia cutis, which is smooth-raised painless skin lesions. They would also have a history of frequent infections. Some patients may also present with DIC, gingival hyperplasia, and CNS involvement. For CML, it's typically diagnosed on routine CBC that demonstrate leukocytosis. With myeloid precursor, patient may have mild or non-specific symptoms such as fatigue, fever, malaise, decreased exercise intolerance, weight loss, night sweats, but they can also present with a blast crisis, which have more dangerous or more prominent manifestation as in fever, bone pain, weight loss, and also splenomegaly. For CLL, it's usually indolent disease. It's many patients they diagnosed accidentally actually with the finding of leukocytosis and lymphedema, fatigue. Sometimes it might present also with hematosplenomegaly on physical examination. Next slide. For Hodgkin lymphoma, usually it presents with cervical lymphadenopathy and spreads in predictable manner along the lymph nodes. The spleen is most commonly involved intra-abdominal side. We have also, they can present with B symptom, which include more or equal 10% weight loss in 6 months, night sweats, which require changing of clothes, and fever above 38.5. Symptoms might indicate a more bulky disease and worse prognosis. In non-Hodgkin lymphoma, the presentation varies with the histological subtypes and the site of the disease. Some subtypes of non-Hodgkin lymphoma can manifest as lymphadenopathies for years, and some of them might be more aggressive. For aggressive type of Hodgkin lymphoma, they might present with the P symptoms as similar to those of Hodgkin lymphomas. For indolent lymphomas are often insidious, and they are slowly growing with waxing and waning symptoms of lymphadenopathy for months or even years. Sometimes they are also presented with hepatomegaly and splenomegaly, and it could be also present with cytopenias. For multiple myeloma, we have the famous back pain, which presents 80%, which is the common presentation, up to 80% of patients. We also have the hypercalcemia, which we also all know the mnemonic stones, bones, abdominal moans, and psychiatric overtones. They can also present with pathological fractures, fatigue, frequent infections, and secondary to dysregulation of antibodies, although they have a lot of expression of antibody, but it's all of them are dysregulated. Exam could receive pallor, fever, and bone tenderness and lethargy. Next. So for investigation for leukemias and lymphomas, first thing to ask for is CBC with differentials. It might show anemia, macrocytosis, leukocytosis. For leukocytosis to be considered as for AML as part of leukemias, it should lack the cytogenic changes that occur during the infections, and we will have a decrease of alkaline phosphatase, which will differentiate AML and CML from a leukemoid reaction, where we have increased leukocyte alkaline phosphatase, and there will be cytogenic changes of the WBC. In CLL, we will have an isolated leukocytosis with a normal hematocrit and platelets seen on CBC. For preferred year, for AML, we have the characteristic class myeloblast, and we will see also our roads, crystals. For CML, for CML, I will make it more quicker. For CML, we will show mature myeloid cells, and for CLL, there is predominance of small lymphocytes and also smudge cells on peripheral sphere. Bone marrow is important, especially in CML, where we show hypercellularity, and the blast cells in AML will express myeloperoxidase, show in myeloperoxidase staining. Next slide. You can also order coagulation panel, serum electrolyte, serum uric acid, serum lactic dehydrogenase, and renal function and liver function. We can also order genetic tests for karyotyping and fluorescence and fish testing. Next slide. Here's our list of common genetic consequences that are in certain leukemias. We can find it in certain leukemias. Next slide. And these are certain genetic translocations that can be seen in different types of lymphomas. Next slide. In case of Hodgkin and non-Hodgkin lymphoma, we can do lymph node biopsy, PET scan, CT scan for the staging of these cancers. We can do skin biopsies in T-cell lymphomas, and we can do bone marrow biopsy. We can also do serology of hepatitis, EBV, and HIV testing. For multiple myelomas, we diagnosis with urine protein electrophoresis and serum electrophoresis. Next slide. So for management of different type of leukemias and lymphomas. Next slide. Management of leukemia often include intensive treatment. That's why we require adequate medical fitnesses, which include determination of level of physical functioning. For example, performance status measurement of comorbidities and cognitive and function. Beside that, we have to have a comprehensive assessment of comorbidities in this population using special scoring system. This is the ECOG scores for determining the medical fitness. Next slide. And we have here the Carson comorbidity index. Next slide. For treatment of AML in fit patient, we includes intensive remissions, intensive induction therapy. We have to assess for the response of the induction therapy, and we have a post-remission management. For induction therapy, we will go for anthracycline-based chemotherapy, as well as for consolidation chemotherapy. These are list of indication. Next slide. We can measure the response of induction therapies by judging the morphological response of blood and bone marrows. Response on blood and bone marrows. We have to do a post-remission management because unless we do that, we will have a relapse in almost all the cases of AML. For post-remission management, we have two types. We have consolidation phase, we have the maintenance phase. For consolidation phase, is more intensive treatment based on cytarabidine-based chemotherapies or hematopoietic stem cell transplantation. For maintenance phase, it's more of lower intensity treatment, which we'd be doing for a month to years. We can also use all trans-retinoic acids in both induction and maintenance. And we can do, as I mentioned, bone marrow transplantation in people who have poor prognostic factor. Next slide. Next slide. For CML, we can use tyrosine kinase inhibitors. They are the first line for CML. And we can also use bone marrow transplantation in such cases. There are other agents we can use instead of tyrosine kinases, such as alpha interferon alpha hydroxyureas and cytoarginines in patients who cannot tolerate tyrosine kinase, such as pregnant lady. Next slide. For patient with CLL, we have induction of treatment. We don't usually treat all patients with CLL. We only treat them if the patient in active phases, and we have criteria, as you can see. A criteria is done by the International Workshop of Chronic Lymphocytic Leukemia for the active phase that we can target the patient. We can target the management of patient in. Next slide. For early stage of CLL, we only observe for a period of 12 months. And based on this observation, we can choose the line of management. For patient with asymptomatic small cells cancer, leukemia, we can give them radiation therapy. Next slide. This is protocol management for chronic lymphocytic leukemia. Next slide. For management of lymphoma, for Hodgkin lymphoma, we have the ABV cocktail, which is count for doxorubicin, bleomycin, and venlafaxine, and dacarbazine. We can do it alone or with radiation to the field involved with the lymphoma. For non-Hodgkin lymphoma, we have rituximab, which is a monoclonal anti-CD20 as preferred regimen. For treatment of high-grade non-Hodgkin lymphoma, there might be a complicated by tumor lysis syndromes, hyperkalemia, hyperphosphatemia, and hyperuricemia and hypocalcemia. We have to treat it aggressively with hydration and allopurinol. For gastric maltomas, we can treat by using antibiotic for treatment of H. pylori. And for HIV-related non-Hodgkin lymphoma, we can use HER treatment of HIV. Next. For multiple myeloma treatment, we aim to reduce the burden of the tumor and relieving the symptoms. We can use microglobulinins as prognostic marker. We can use the chemotherapy as melphalan and steroid, plus or minus thalidomide. Stem cell transplantation is used in patients who are less than 60 years of age and in advanced stages of disease. Treatment of alleviating the symptoms, we use hydration for hypercalcemia and glucocorticoids and diuresis. For bone pain, we use bisphosphonates and local radiations. For renal failure, we use we give hydration to aid the excretion of blood chains. In infection, we use vaccination against preventable diseases. And in anemia, we can administrate erythromycin. Next. This is the end of my presentation. Thank you everyone for listening. I'm sorry for taking such a long time, but it's hematology and I barely scratched the surface in this. If anyone have any disease, you can ask me now or you can email me in my email. I will like to give the stage to my fellow Dr. Eiman Abdallah, who will continue the presentation from here on.
Thank you, Dr. Marwa. Hello, Dr. Nadir, and hello, everybody. My name is Eiman Abdallah, and I will be talking about platelet and coagulation disorder. So let me share a screen. Can you see my screen?
Yes.
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 Yeah. Okay. A brief overview. Bleeding disorder are rare in older adults, but they can cause serious risk. Mucocutaneous bleeding. Mucocutaneous bleeding typically indicate an issue with platelet quantity or function. Bleeding that occur in tissue or joint is more commonly linked to coagulation disorder. Thrombocytopenia. Thrombocytopenia is characterized by platelet count of less than 150,000 per microliter, and it is often prevalent in older patients and typically has multiple contributing factors. In cases of low platelet, it is important to consider a serious condition such as disseminated intravascular coagulation, thrombotic thrombocytopenic purpura, TTP, hemolytic uremic syndrome, or heparin-induced thrombocytopenia. First, disseminated intravascular coagulation. It is commonly associated or linked to severe infection or disseminated cancer. It typically manifests with intravascular hemolysis or consumptive coagulopathy. The key signs include red cell fragmentation, low platelet, hemosiderin in urine, and prolonged prothrombin and partial thromboplastin time. And treatment involve addressing the underlying issue and providing blood products such as fresh frozen plasma and cryoprecipitate. Cryoprecipitate if fibrinogen is less than 100 nanogram. About TTP and HUS, both are characterized by microangiopathic hemolysis and thrombocytopenia, making it challenging to differentiate. But TTP is marked by neurological symptom and kidney dysfunction, while HUS primarily involve renal issues. Initial management for both conditions include supportive care along with fresh frozen plasma or cryoprecipitate. And also TTP typically respond well to plasma exchange, while HUS tend to be less responsive to this treatment. Heparin-induced thrombocytopenia, it develops after exposure to heparin product, and antibodies form against complexes of heparin and platelet factor 4, which then bind to Fc receptor on platelet, and this lead to increased platelet activation. The definitive diagnostic test is a serotonin release assay. It is a medical emergency that require immediate treatment with direct thrombin inhibitors. Idiopathic thrombocytopenic purpura. It is diagnosed by ruling out other potential causes. Symptomatic patients typically receive treatment with intravenous immunoglobulin and tapering dose of steroid. If initial treatment are ineffective, the other options could be splenectomy, chemotherapy agent such as danazol or rituximab, or thrombopoietin receptor agonist. Thrombocytosis. Thrombocytosis is often reactive, but can also be caused by an underlying bone marrow mutation. Essential thrombocythemia is classified as myeloid proliferative neoplasm and is associated with acquired mutation in JAK2, CALR, or MPL. Bone marrow biopsy is essential for confirming the diagnosis. Based on the patient age and clinical situation, treatment may involve cytoreductive medication in addition to aspirin to lower the risk of thrombotic event. Qualitative platelet problems. It is mainly platelet function disorder, although it is rare but can cause bleeding in older adults. Classified as hereditary and acquired disorder. Hereditary disorders such as Werner-Solier syndrome or Glanzmann thrombocythemia, and the most acquired disorders are typically caused by medication, particularly aspirin or non-aspirin NSAID. Platelet function testing is valuable for identifying the underlying cause of these disorders. Clotting disorder, also it could be acquired or inherited. Common acquired prothrombotic conditions include antiphospholipid syndrome, cancer, trauma, and surgery. Common inherited clotting disorder consists of prothrombin gene mutation, protein C and S deficiencies, and factor V laden. Antithrombin deficiency can both acquired and inherited clotting disorder and caused by defect in inhibiting thrombin and activated factor 9 and 10, which is a result in hypercoagulable state. Most thrombotic events in older adults are provoked and require a limited period or short duration of anticoagulation. The chest antithrombotic therapy for venous thromboembolic disease guidelines and expert panel report provide reliable guidance on treatment duration and medication choice. For older patients with unprovoked or recurrent thromboembolic event, it is advisable to conduct lab tests for inherited clotting disorder. And studies show that up to 10% of selected octogenarians with recurrent clots may have genetic mutation. Bleeding disorders. In older adults, bleeding disorders are often acquired, typically related to liver disease or deficiencies in clotting factors. And the von Willebrand disease is one of the most common bleeding disorders. Older adults can develop circulating factor inhibitors, which may present with symptoms like that of hemophilia. The most inhibitor is to factor 8, which can have a sudden onset leading to significant bleeding in soft tissues, such as muscles, unlike joint bleeding, which is seen in congenital hemophilia. And treatment generally involve factor replacement therapy. Also, it could be deficiency of vitamin K-dependent clotting factor, which is occur in older adult. Common causes of this deficiency include disorder of hepatobiliary system, antibiotics that disrupt the bowel bacteria, which is crucial for vitamin K production, or it could be malabsorption issue or severe malnutrition. Fortunately, these deficiencies can be effectively treated with oral or intravenous vitamin K. All patients who need warfarin reversal should receive vitamin K replacement. Subcutaneous administration of vitamin K discouraged because of its lower time to correction of prolonged INR, and it has variable absorption. In patients receiving warfarin who have severe bleeding or unable to receive fresh frozen plasma and need urgent reversal, consider 4-factor prothrombin complex concentrate and 3-factor prothrombin complex concentrate plus recombinant activating factor 7. Thank you so much.
Thank you so much, Dr. Eiman. Now we'll leave Dr. Wessam Omer to present our next topic from the white team.
Assalamu alaikum.
Wa alaikum assalam wa rahmah.
Can you hear me?
Yes, we can hear you.
Okay, 1 second. Let me share my screen. Okay, so hello, Dr. Nader, and hello, fellows. My name is Wessam Omer. I'm from the white team. And today my presentation is about how to develop a quality research article and avoid a journal desk rejection, abstract, or manuscript submission. So the agenda for today is a brief presentation. After the introduction, I'll go through some definitions and then causes and solution of desk rejections, and then the conclusion. So we all know that academic publishing is a crucial aspect of research and scholarship. And submitting a journal article can be daunting for many scholars. And while publication process can provide valuable exposure and recognition for one's work, it still can be time-consuming and frustrating, especially if the submission is rejected. And receiving a desk rejection can be disappointing, but it's important to remember that it's not necessarily a reflection of the quality of our work. And desk rejection can occur for a variety of reasons. We will explore that in the coming slides. Now let's learn some definitions. So what is a manuscript? Manuscript is a handwritten or typed document. It's the writer version of document before publication. It's basically a comprehensive report outlining the research question, the methodology, the data analysis, and the key conclusion reached. Any research paper is known as a manuscript in the publication stage. The abstract is a concise summary of the key point of a research article. Usually it's 150 to 250 word paragraph. It's usually placed at the beginning of the article, and it gives the reader a quick overview of the main ideas and findings. It might be the only thing the editor reads, and depending on your abstract quality, he or she can either accept or reject your paper. That's why it should be written in the best way possible. The article is a complete published research piece. It includes the introduction, the methods, the result, discussion, and conclusion. So the main difference between the manuscript and article is the publication. Manuscript is like before or pre-publication, and article is after you publish your paper. Now we're going to talk about desk rejection. So desk rejection is the rejection of the manuscript before external peer review. And the term comes from the idea that the editor is working at their desk to make the initial decision on your paper. It's a common practice for journals to save time or to give authors a quick turnaround. Depending on the journal type, 40% or up to 75% of the submitted manuscript are desk rejected. So it's important for the authors to have a thorough knowledge of the process flow and appreciate the reasons for the desk rejection. In this slide, I will explain the process on how to get your paper to publication. So here we have the researcher drafted his paper and ready to send it to the journal of choice. The paper reaches the editor. The editor can either reject your paper from the beginning, and we call it desk rejection, or he can accept it and send it to some reviewers, usually 2 to 3. The reviewers can still reject your paper. We call it rejection after review. Or they can read through it, put some comments, and then send it back to the researcher to fix some areas or to do some experiment until, it go back and forth until it reach the final or the satisfying version. Even at that point, it can still be rejected. We call it rejection after review, or finally be accepted and ready to be published. Now let's talk about the desk rejection causes and solutions. So some of the main causes of rejection is inappropriate scope. Means the manuscript does not fit the journal's aims and scope, or it falls outside the journal's area of expertise. And the solution is to choose the right journal for submission. Another cause is poor formatting, like incorrect margins, font size, or spacing. And the solution is to pay close attention to the submission guidelines and formatting requirements by that journal. Another cause is lack of originality. It means your paper does not contribute a new knowledge or insight to the field, or the researcher has already published that paper elsewhere. And the solution is to conduct a thorough literature review and ensure that the manuscript addresses a novel question or provide a new perspective to the existing question. Another cause is incomplete manuscript, like missing essential components such as abstract or missing introduction or missing conclusion. And the solution is to ensure that the manuscript includes a complete and accurate data. Continue in the causes. It can be simply language and grammar issues. And the solution is to carefully proofread your paper for errors and ensure it follows academic writing conventions. One of the main causes is the flawed methodology, means your research design or data analysis or your methodology is insufficiently described, or you have insufficient sample size or lack of control group or lack of reproducibility of the result. And the solution is to ensure that the methodology is clearly explained and the data collection and analysis procedures are clearly described. And finally, ethical concerns can be a cause of rejection, like plagiarism or data fabrication. And plagiarism is the practice of taking someone else's work or ideas and passing them off as your own. And the solution for that is to carefully review the ethical guidelines of the institution and the target journal, and never plagiarize or fabricate the data. These are other causes for rejection with no solution, like when the journal may not have space for your paper, or the paper cannot compete with the high quality of the other papers submitted to that journal, or the journal may have recently published a very similar paper, or maybe just simply editor publication bias. In conclusion, we need to know that rejection rather than acceptance is the norm in academic publishing, and that most papers end up getting published if authors stay persistent. So don't give up, keep refining and trying, and good luck with your research, and may your rejections be kind and few. Thank you.
Thank you very much, Wissam, for the thorough presentation. If you have any question, you could ask her. And if not, we should move on with the next presentation with Dr. Walaa.
Hi, everyone. Thank you for your patience. Can everyone hear me very clearly? Can you see the screen?
Yes.
Yes.
Yes, we can see.
Yes, we can.
Okay. Sorry, everyone. Okay. This is a brief introduction to secondary data analysis and research. My name is Walaa Mohammed. I'm from Team Walaa. So what is secondary data analysis? It means using existing data collected for a different purpose to conduct new research. And the main issue for this method is it is cost-effective and efficient, allowing researchers to explore new hypotheses or answer different research questions without the need to collect new data. It is commonly used in epidemiology and public health studies to analyze large data sets, such as electronic health records, insurance claims, and health surveys. So the advantage of this method of secondary data analysis, first, as we said, cost-effective. You don't need to collect new data. It is time-saving. You already have the data. Large database sets, access to extensive data, sometimes spanning many years. And from ethical perspective, it reduces the burden on participants, especially in sensitive areas. The disadvantage that investigator has little to no control over what data they have been collected and how. So the data relevance may not fully fit the research question. The data quality and potential issues with the accuracy or completeness of the data may be affected. Also, there is a big issue of bias. Original data collection methods may introduce some bias. Also, the lack of control because the limited ability to influence the data collection process or follow-up questions. So what are the sources of secondary data? First, we have governmental publications, like data collected by government agencies, such as health statistics, census data, and economic reports. Also, academic journals, through research articles, reviews, and meta-analysis, and healthcare records, and insurance claims and patient registration. Also, surveys and questionnaires, like the national health surveys, like the behavior risk factor surveillance system, and the NHIS. Also, we can use market research reports, data from market research firms that provide insight into the healthcare trends and patient behavior. Also, public vital statistics like birth and death record, marriage and divorce statistics, and other vital records. And of course, we can use non-governmental organizations, the reports and data collected by them from working in healthcare and public health. So how do you approach this data? Either one of the famous methods is systematic review. We conduct a review of existing literature and database to identify relevant data or resources that have already been collected. We can do something called data mining, which is extracting useful patterns and knowledge from large data sets using statistical and computational techniques. We can also do meta-analysis, so combining data from multiple studies to identify overall trends or effects, increasing the statistical power or reliability of the findings. Also through data reuse and ancillary studies, which is repurposing data collected for one research question to address a new questions, ensuring ethical guidelines and data privacy are maintained. Also, we can do data-based linkage, which is interrogating data from different resources to create comprehensive data sets that can provide deeper insight. So we always hear about something called pyramid of evidence. The pyramid of evidence represents the hierarchy of research evidence in healthcare. Each level of the pyramid represents different evidence quality, with higher level providing more reliable and rigorous findings. In the bottom, we have animal and laboratory studies, and the studies with no design, like case report and case series. And then we go up for the observational studies, like case control studies and cohort, and the primary randomized control trials. And on top of the pyramid, we have secondary or pre-appraised data or filtered, which is meta-analysis and systematic review. And this will translate into clinical practice guidelines. So what is systematic review? Systematic review is a methodical and comprehensive synthesis of research on particular topic, identify a set of complete studies that address a particular research question, and evaluate the result of these studies to arrive to conclusion about the body of the research. Hand in hand, we come with meta-analysis. Meta-analysis is a statistical aspect of systematic review. The statistical technique combines the results of multiple studies included in a systematic review. It answers the question, what is the overall effect when we pull all these results together? So this diagram shows you that the interaction between them and how we have something called the traditional or narrative review data. It is all data that are not systematically collected. And then we go to more sophisticated form, which is systematic reviews. And then we want to have statistical analysis. We use meta-analysis from the systematic reviews. So what's a traditional narrative review? It is also known as a narrative literature review. It's a comprehensive analysis of existing literature on a specific topic. Unlike systematic reviews, narrative reviews don't follow a strict methodological approach. Instead, they provide a descriptive overview of key concepts, theories, and findings related to the research topic. Narrative reviews are useful for establishing a theoretical framework, identifying trends, and providing context for new research. They are often more flexible and can include a broader range of studies, but they may also be more subjective due to the lack of standardized processing. So what's the process and methodology using systematic review? You should follow these steps to have a strict methodology. First, you have to start with a clear research question, start with a clearly defined one, comprehensive research, use systematic methods to search for all relevant studies, then you selection criteria. You should apply strict inclusion and exclusion criteria to selected studies. Then the other step is data extraction. We extract data from selected studies systematically. After that, we have to do quality assessment, assess the quality of the studies collected, and then you synthesize. You combine and you synthesize the data to answer the research question. Finally, the reporting process, presenting the finding in a clear and transparent method. Okay, so who can do the systematic review? It can be done by independent authors, by Cochrane collaborations, academic institutes, healthcare organizations, and governmental agencies like HRQ, ICER in the US, and there is different other governmental agencies depending on the country, and non-governmental organizations which focus on health and medicine often conduct systematic reviews to support their advocacy and program development. So actually anyone can do it. Systematic review application in statistics. First, we can use it to generate clinical guidelines. They inform evidence-based clinical guidelines and recommendation by summarizing the best available evidence. They are used for policy making, help policymakers make informed decisions based on a comprehensive evidence. They use for identifying research gaps, highlight areas where more research is needed, and guiding future studies. They are used for patient care to improve patient care by providing healthcare professionals with a thorough review of effective treatment, and for educational purpose, serve as a valuable resource for teaching and training in medical education. So, of course, it has its own challenges. So what the challenges we have? It is time consuming. Conducting thorough review can take months, sometimes even years. And we have the bias factor. There is a risk of publication bias, where studies with positive results are more likely to be published and included. We have the heterogeneity. The study design, population, the outcome variation can make combining and comparing results difficult. And the quality of included studies. The overall quality of systematic review depends on the quality of the individual studies included. Finally, the data availability. Not all data from the original studies may be available, leading to incomplete analysis. So how we can attempt to reduce bias, which is a big factor in in systematic reviews. We can do a comprehensive research. They use extensive search methods to include all relevant studies, reducing publication bias, clear and inclusive exclusive criteria that establish and follow strict criteria to select studies ensuring consistency and objectivity, quality assessment. Each study quality is evaluated using standardized tools, minimize the influence of poorly conducted research. We can do data extraction, which is a systematic approach to extracting data, ensure accuracy and reduce the risk of error, and double checking and transparent reporting. Then we have meta-analysis. When we use it? We use it to increase the statistical power. Meta-analysis can detect effects that may be missed in individual studies by pooling data from multiple studies. We use it for resolving uncertainty. It helps to clarify whether an effect exists when individual studies may have conflict results, to generalization finding, and providing a more comprehensive view by combining results from different setting, population, and methodologies. We use it also to improve precision, reduce random error, giving a more precision estimate of the effect size, and for exploring subgroups, allow for subgroup analysis to be understand variation in effect across different study conditions or populations. A famous example for using of meta-analysis, there is a study on vitamin D supplementation and the prevention of fracture. Individual studies on this topic had mixed results, which some showing benefits and other not. But combining data from multiple studies, the meta-analysis provided a more precise estimate of the effect, resolving the uncertainty and demonstrating a statistically significant benefit of vitamin D supplementation, reducing the risk of fracture. Okay, so what to avoid when doing meta-analysis? Insufficient studies. There aren't enough studies to provide meaningful results, the poor quality data, the heterogeneous data, and the qualitative data. The data is qualitative and cannot be statistically combined, and inconsistent reporting. Studies don't report their finding in a way that allows for data extraction and pooling. So what to take from this? In the world of data, there is a saying, garbage in, garbage out. If the studies are working with are flawed or inconsistent, the result of your meta-analysis will be equally unreliable. And as we talked about heterogeneity, don't mix apples with oranges. It means avoid doing a meta-analysis when the studies are too diverse in terms of methodologies, population, or outcome. And that's the presentation for today. Thank you for your time. Thank you, everyone. Do you have any question?
Thank you, Dr. Walaa, for the presentation.
Thank you, Dr. Samira.
So the next will be presenting. If no one have any question for Dr. Walaa. Then Dr. Einas and Dr. Noura will be presenting the next topic in the agenda. Are you ready?
والله شوية بس مختار لحظة بس.
Hello, can you hear me?
Yes.
Yes. Dr. Einas and Dr. Noura, if you are ready for presenting your next topic.
Yes, we're ready. Dr. Noura, can you share the screen?
Okay, just a second.
Okay, take your time.
Hello, everyone. Can you hear me?
Yes, we can hear you.
Okay. I'm Dr. Einas Tahir from the team TAN 1, and I'm going to be presenting today along with Dr. Noura the role of acute care prescribing in the opioid epidemic. Okay. Just wait a second. Okay, so we have here opioid overdose is actually a leading cause of injury-related deaths in many countries, especially in the United States. So this epidemic has been driven by the overprescription of opioids in both the acute and chronic care settings. Next. Currently, the CDC guidelines for prescribing opioids, according to the last update, which was in the 2022, the CDC guidelines are one of the most widely referenced for opioid prescription in the United States. It recommends the following. We have acute pain management. We should limit opioid prescription. It says that the opioid prescription should be limited to 3 days or less because evidence have suggested that most acute pain can be effectively managed within this time frame, and longer prescription is going to increase the risk of misuse and dependence. That's first. Second thing, we should use the lowest effective dose. We should start with the lowest possible dose of immediate release opioids, and then we should avoid prescribing extended release or long-acting opioids for acute pain. Third thing we have is evaluating the risks before prescribing. So we should assess the patient's history of substance use or other factors that may actually increase the risk of opioid use disorder. Lastly, we should follow up and reassess the patients, and all providers should reevaluate the patients if opioid use continues beyond 3 days. We should ensure that continued opioid use is actually necessary and appropriate. Next. We should also consider non-opioid alternatives. We should always prioritize giving non-opioid treatments like ibuprofen and naproxen and acetaminophen. These should be the first-line treatments for acute pain, the NSAIDs, first thing. Second thing is the multimodal pain management. The multimodal pain management, it says that for severe acute pain, we should actually consider combining different types of non-opioid treatments. We should combine local anesthetics, physical therapy, cognitive behavior therapy, all of that in order to reduce the need for opioids. Next. Next is tapering opioids. So we should always discontinue opioids as soon as possible. So if opioids are actually prescribed, they should be discontinued as soon as pain has been managed by non-opioid methods. And this tapering should be gradual, okay? It should be gradual to minimize withdrawal symptoms. Next. So the last thing that I'm going to speak about is the opioid use in acute care system settings. So the common reasons for prescribing opioids is actually in acute injuries, severe pain management, post-surgery or trauma. We have pain from acute illnesses like kidney stones or burns. And the last thing is the prescription practices. Okay, so we have the high potency opioids is often prescribed due to the immediacy of pain relief needed in acute care settings. This is the reasons. Next, I'm leaving the stage for my colleague, Dr. Noura Mohammed.
Hello, everyone. My name is Noura Mohammed. I'm a member of Pink Team. Thank you, Dr. Einas. I will be continuing this presentation from here. So first, let's discuss how acute care prescribing practices contribute to the opioid epidemic, focusing on 3 key factors. First, overprescription and inappropriate dosing. A study published in the PMG in 2017 found that emergency room patients are frequently prescribed 5 to 7 days worth of opioids, despite evidence suggesting that acute pain from most conditions can be effectively managed in just 3 days or less. Furthermore, data from CDC indicate that even a single one-day opioid prescription can lead to a 6% risk of long-term use, with that risk increasing to 13.5% for prescriptions of 8 days or more. These patterns highlight that acute care physician may often prescribe more opioid than necessary, resulting in leftover medication that can contribute to misuse. Lack of alternative. Another contributing factor is the frequent lack of alternative. In many cases, opioids are prescribed as the first-line therapy without considering non-opioid pain relievers or multimodal pain management approaches. The dependence on opioid limit patient options and increase the risk of long-term dependency. Mismanagement of prescription. Lastly, mismanagement of prescription play a critical role in this epidemic. There are often inadequate guidelines for tapering of opioid or managing withdrawal symptoms after acute pain treatment. This lack of clear protocols can lead to long-term dependence on this medication. Risk of transition from acute to chronic use. Let's examine the risk associated with the transition from acute to chronic opioid use, highlighting two critical aspects. First, increased risk of long-term use. Patients who are prescribed opioid for acute condition may develop tolerance or dependence on this medication. Research indicates that up to 1 in 12 patients prescribed opioids in emergency rooms continue using them months later, raising significant concern about chronic use stemming from short-term prescription. Getaway to addiction. Another significant risk is that acute opioid prescription can act as a getaway to addiction. Initial exposure to opioid may lead to misuse and in some cases, progression to illicit drug use, such as heroin. Some patients may develop opioid use disorder following their exposure during acute pain management, underscoring the importance of care for prescribing. Now we will talk about the effort to improve acute care prescribing practices, focusing on three primary strategies. First, Prescription Monitoring Program, PMPS. Many regions have implemented electronic systems designed to track opioid prescriptions. These programs help detect patterns over prescriptions, allowing healthcare providers to monitor patient prescriptions histories when it's necessary. Updating prescribing guidelines. The second effort involves updating the prescribing guidelines. Current guidelines emphasize a more conservative approach to opioid prescribing, recommended shorter duration and lower doses organization like the CDC advocates for considering a non-opioid alternative such as NSAID or physical therapy and so on when it's appropriate. Number three, and finally, and perhaps the most important effort, is the focus on patient education. Educating patient about the risk associated with opioid use, as well as providing guidance on the proper disposal of leftover medication is the critical for reducing misuse and promoting safe practice. Role of acute care provider in managing pain and addressing the opioid crisis. As we consider the role of acute care provider in managing pain and addressing the opioid crisis, there are three key areas to focus on. First, responsible prescribing. Physicians in acute care setting must strike a balance between effectively managing pain and minimizing the risk of opioid dependence. This means utilizing opioid only when absolutely necessary and prescribing them for the shorter duration possible. Collaboration with chronic care. It's essential for acute care provider to ensure proper follow-up with primary care or pain management specialists. This collaboration is critical in preventing patients from transition to long-term opioid use. Innovation in pain management. Finally, hospitals and clinics are actively exploring alternative therapies to reduce dependence on opioid in acute setting. Approach such as a nerve block and physical therapy not only offer effective pain relief, but also help minimize the need for opioid prescription. So by focusing on responsible prescribing, collaboration with chronic care, and innovative pain management techniques, acute care provider can play an important role in addressing the opioid epidemic while ensuring patients receive the care they needed. Thank you, everyone, for your attention. We have here some questions regarding the presentation, and we would love to hear your answer. First question, what are some non-opioid alternatives for managing of acute pain? Do you have any answers? Hello, can you hear me?
Yes, we can hear you. Feel free to unmute yourself or answering the chat box.
Yes, please. Give me an example for alternative non-opioids.
We can do Tylenol. We can also do non-steroidals.
Okay. Sounds good. So, what about what role do prescription monitoring programs, the PMPs, play in opioid prescribing? Do you have an idea?
So these also control the prescriptions. So for patients, so they're not able to fill prescriptions from different providers and getting opioid dependent or overdosed. So it monitors exactly how many pills they're taking and how frequently.
Okay, excellent answer. Thank you very much. So, do you have any questions before we finish our presentation? No question then. Thank you very much, Dr. Nader and Dr. Samira.
Thank you very much for the presentation, Dr. Einas and Dr. Noura. If no one has question, we can move on to the next agenda. We will be talking about depression with Dr. Sondas Gargum, if I'm saying your name right. Feel free to share your screen whenever you are ready.
Hi, everyone. I'm just going to share my screen here.
Yes.
Okay, you can see my screen?
Yes, we can see your screen.
Perfect. Hi, everyone. My name is Sondas Gargum, Dr. Samira. Yeah, thank you so much for the introduction, and thank you, everyone, for being here today. And thank you, Dr. Nader and Dr. Samira, for allowing me to present. I don't want to take up too much of your time, so I just want to briefly discuss depression in geriatrics and why it's important for us as physicians to be aware of it and how to recognize it. So what is depression? Depression is a very serious mood disorder that can affect the way you feel, act, and think. It is a mental state of low mood and aversion to activity. It is a common problem among older adults, but it is not a normal part of aging. So it does need to be recognized and dealt with in order to maintain a good quality of life. How common is depression in the geriatric population? The statistics of depression according to Mental Health America states individuals aged 65 and older account for 20% of all suicide deaths, white males being the most vulnerable. More than 2 million Americans aged 65 and older suffer from some form of depression. 68% of adults 65 and older know little to nothing about depression, and only 38% of them believe it is actually a health problem. So this just goes to show that although we have come a long way in increasing awareness of mental health issues, we still have a lot of work to do in supporting our older adults when it comes to their mental well-being. So what are the types of depression? The 4 types we need to be aware of are, number 1, major depressive disorder, which includes symptoms lasting for at least 2 weeks that interfere with a person's ability to perform daily tasks. Number 2, persistent depressive disorder, which is a depressed mood that lasts longer than 2 years, but can still perform daily tasks, unlike major depressive disorder. Number 3, substance medication-induced depressive disorder, which is depression related to the use of substances like alcohol or pain medication. And number 4, depressive disorder due to medical condition, which is depression related to separate illnesses like cancer or multiple sclerosis. So what are the risk factors for depression? Some may experience depression after a major life event, like a medical diagnosis or death of a loved one, or any other major life stressor. And others may become depressed for no clear reason at all. But it's important to recognize risk factors that may lead to depression, which include isolation and loneliness, stress, sleep problems, lack of physical activity, functional limitations that make engaging in activities of daily living difficult, substance abuse, and genetics. So people with family history are of higher risk for depression. What are the signs and symptoms of depression that we need to be aware of? So depression in older adults is not as easy to recognize as it is in younger people because of the difference in symptoms. For example, in the older population, sadness is not their main symptom. They sometimes exhibit feelings of lack of interest in activities or feeling too fatigued to do anything at all. But the main symptoms and signs we should be aware of include sleeping difficulties or sleeping too much, diminished interests, feeling of worthlessness and guilt, loss of energy, concentration difficulties, appetite abnormality or weight changes, psychomotor agitation, and suicide acts or thoughts of suicide. What about depression in those with dementia? Diseases that cause dementia can damage parts of the brain involved in emotions and behavior. Factors contributing to depression and dementia include side effects of medications, especially sleeping pills, steroids, and drugs used to treat diseases like Parkinson's, chronic pain and other chronic symptoms, and not getting good quality sleep. People with dementia are much more likely to become depressed if they had depression in their past. And it's important to remember that depression increases problems with thinking and memory loss caused by dementia, and contributes to changes in behavior, such as becoming more agitated or not wanting to eat. And in a bit, I'll discuss the screening tool used to screen for depression in those with dementia. So how can we prevent depression? So we all know that the best way to prevent depression is just making healthy lifestyle choices. So we should encourage the elderly to be physically active, eating a balanced diet. For example, low sodium DASH diet has been shown to decrease the risk of depression, getting enough sleep each night, keeping connected to your friends and family, and having them participate in activities, especially the activities that they enjoy. And what are the treatment options for depression? Just really quickly, the first that we should be aware of is psychotherapy, and psychotherapy or talk therapy is used to help a person identify and change troubling emotions, thoughts, and behavior. So examples of approaches specific to psychotherapy include cognitive behavior therapy and interpersonal therapy. Another option we use is medications. And in the older population, the second generation antidepressants like SSRIs and SNRIs are recommended for older adults due to their reduced risk of side effects. It's recommended to combine these medications with interpersonal psychotherapy for better results. And shared decision-making between the patient and provider is recommended, as individuals may have different response to the medications or concerns of the side effect profile. Another option we use is electroconvulsive therapy, or ECT. So this is when we apply electrodes to the head and a patient, or we enable a mild current to pass through the brain of the patient. And this is used to treat severe depressive episodes. And it's usually only considered if a patient's depression did not improve with medication or with psychotherapy. And the two criteria that must be met in order to use ECT includes: one, having severe treatment-resistant depression, and two, requiring a rapid response due to life-threatening situations such as suicide or malnourishment. And the final thing we can use is transcranial magnetic stimulation. This is also used in treatment-resistant depression. It's non-invasive, and we use an electromagnet to stimulate the brain using low-intensity impulses that stimulate the neurons. And unlike electroconvulsive therapy, which applies electricity directly to the head, transcranial magnetic stimulation uses a magnet stimulation to specifically target certain brain sites. And the screening for depression include the 5-item geriatric depression scale, the 15-item geriatric depression scale, or the 30-item geriatric depression scale. And these do not assess for somatic issues because this is thought to interfere with the diagnosis. The 5 and the 15-item geriatric depression scale has a sensitivity of 94% and a specificity of 81%. And in summary of what the screening questionnaire is, basically we just ask questions with a yes or no response to how the patient has been feeling in the past week. And for screening those with dementia, we use a 19-item screening tool called Cornell Scale for Depression and Dementia. And this screening tool can be used in patients unable to communicate well, and it can also be given to the caregiver to answer these questions. And this screening tool has a sensitivity of 93% and a specificity of 97%. And I just want to quickly mention that it's important to remember that these are just screening tools. They're not diagnostic tools. So they highlight whether an older adult is vulnerable to depression and can give us clues if they should be referred for further evaluation. And how do we discuss the topic of depression in older adults? So when you're concerned, you want to approach them in a compassionate, calm, and straightforward way, saying things like, hey, I noticed that you're not acting like yourself lately, and try to describe things that you've noticed in their behavior change. For example, you might have noticed that they don't go outside as they used to, or they've been staying in bed all day, or you've noticed changes in their appetite, and just see if they'd be willing to chat with you about it, or you can offer to help connect them to a mental health professional if they're not comfortable with you to talk to you about it. And if they decline your offer at first, just be patient with them and maybe try to bring it up again at a later time. But it's important not to ignore it because depression is never a normal part of aging. When you see something, please say something. And thank you all for listening. Thank you for being patient.
Thank you very much, Dr. Sondas, for the presentation.
Yeah.
I will let if anyone have any question, you could ask. If not, we will be moving on for our last topic on the agenda. We will be talking about a Google interview warm-up with Dr. Samahir Mutwali. So if you are ready, Dr. Samahir, you could start sharing your screen.
Thank you, Dr. Samira. Thank you very much. So, okay. Can you see my screen now?
Yes, we can see your screen.
Okay. So my topic is kind of,
What are your career goals for the next 5 years?
It's already start talking. So my topic is kind of like different today because, you know, guys, this is the season. Most people are now preparing for the interview, and most of the candidates now uploaded their ERAs. And Dr. Nader suggested like some new edition of the AI interact with the interview, since he always cared for, I mean, everyone and for every little details. So Google launched a new interview warm-up. It's like an AI made an interview to you. So let me just show you how it works. First of all, if you want to start just the interview, just click here in interview warm-up, okay? This is an example for someone like digital marketing, data analysis. Unfortunately, I couldn't find like for the medical, but you know, like AI, you can adjust, I mean, everything while talking to them. So after you click start practicing, okay? So, okay, let's say we have here data analysis, digital marketing, IT support, which is stuff, I mean, kind of not belong to us. So you can click here in general and now start. Hello?
Hi, let's practice an interview.
Yeah.
Can you please tell me a bit about yourself?
Yeah. And you just answer like, I can say, hi, my name is Dr. Samahir, and IMG, originated from Sudan. I am applying for the match of 2025. I'm an all graduate. I've experienced back in Sudan. I did my internal medicine residency back in Sudan, you know, stuff like this. And you just click done.
Thanks for sharing.
And
Tell me about a time you made a mistake. How did you communicate that mistake?
See, yeah, and then you answer. So it's kind of give you like multiple questions and you answer them. And after that, he analyzes what you say and he can correct you and he can, I mean, or it's, I don't know, like saying it or he, but you know, it can correct you and give you like, as you know, AI like collecting data from everywhere. So he can adjust what's like the most suitable answer to like the main questions in the interview. Okay. Are you sure you want to quit this interview? You can say yes. You can go back there and then I just want to share, there is some details.
You have a question from Dr. in the chat box. She is saying, is it free?
I'm sorry?
You have a question from Dr. Rahma, I think. She's asking, is it free?
Oh, yeah, it is free. Yeah, it is free. Yes, yes. I just need the, yeah, here. Okay. So yeah, it has here like a click. There is interview tips, okay? Before interview. Sorry about, yeah. Okay, before interview, okay, you can like practice is the one of the most way to get more confident and comfortable interviewing. A few tips for practicing. So try to turn off your inner critique and answer authentically as possible. Review your answer from a perspective of an interviewer, which is most importantly, which is part of your answer. Capture the thing you would want to an interview to know about you, which parts feel less relevant. Think about what is the main way you would want to improve your answer, then try answering again, those improvement in mind. Like it's someone like ready and to practice with you, like, I mean, the whole day. So I think it's a very good idea. You take most important tips, you practice, like it corrects some language, it correct like some, give you like some more like delicate language you can talk about in the interview. So, okay, most importantly, keep practicing, and it's okay if it feels hard. That's the main you are improving. Ask yourself a few questions and try to answer them as authentically as possible. Okay, how would you describe yourself? In what area are you talented? What are examples of time you have used this talent? Have you how have you talented help you in succeed in different area of life? You know, questions like this. This is before interview. During interview, okay, listen carefully to each question. It's okay to take a moment to gather your thoughts before you answer. If you are unsure about what's being asked, ask your interview to clarify, okay? Emphasize your skill, accomplishment. Let the interviewer know what your strengths and what excites you, stuff like this. And after the interview, okay, thank your interviewer for their time. You can ask your interviewer for their email address if you would like to follow up with additional question information, and the rest. Okay, it has some tips for answering a specific type of question, like behavioral, like technical, like background question. Let's talk about the background a little bit. Okay, background questions are designed to help the interviewer understand more about your training, experience, and why you want to work in this role. This is one of the important questions. I mean, tell me, why are you fit for this role? So some people like, you took time to prepare for this question in your mind. So it's kind of when you practice like a lot with this interview app or interview website, help you more than, so you'll be ready when you practice personal with someone else. So I think that's kind of so helpful. Okay, when answering broad questions like tell me about yourself, consider structuring your answer in terms of the present, past, and future. Start with the present, talking about your current role, the scope of it, and the recent accomplished you have had. Then speak to the past, okay, explaining how you got to your current role and how other previous experience that's relevant to the role you are applying for. Finally, suit the future and say what you are looking to do next and how this role would help you achieve that. Okay, research can help answer questions like, why do you want to work here? Okay, reread the job description, it's most important, and think about which aspect are interest and excite you. Look at the company's website or like the hospital website you're applying to and social media to get better sense of their values and how they're aligned with yours. Be true to yourself. Be honest about what you want and what you don't want from this role. Do not focus solely on your experience and accomplishment. Think about your talent and passions too. So, sorry. I want to guide you to the first. Okay. Just a second. Let's go to the first. Yes. So here, I mean, it designed the question like background questions. Can you please help me? Can you please tell me a bit about yourself? So
can you please tell me a bit about yourself?
Yeah, you can pick the questions, situational, background, and then background, how would you describe your working style? Tell me about time you made mistake. How did you communicate with this mistake? So you can pick like the area you feel yourself like weak on answering it. So yeah, this is all about it. I wish everyone luck, and I think it's very, very, very helpful. And like sitting in the computer and practicing with it, giving like the idea, the way the other people think here, because AI collecting most of the ideas, most of the questions, like through, I mean, it's not only like medical field, but about like, as I mentioned, IT, data analysis, there is same question, same concept, I mean, everywhere. So I think it's good if you prepare for it with yourself first, and then after that, you like kind of advance yourself and prepare with person in real. So yeah, that's all. Thank you, everyone.
Thank you so much, Dr. Samahir. I think this is a very nice tool. Could you all use it for practicing for this season?
Yeah.
Yeah.
And it's available available anytime. Available anytime.
Yeah, I just send them the link on the chat box.
Yes, sure. And I want to just thank Dr. Nader for all the help he provided for all of us, even in the little details, in the updated details. He's like a really great mentor.
Thank you for the presentation, and thank you all for all the fellows who presented today from different teams and our team, Page One team. And thank you for those who were listening throughout the whole presentation. I hope that you find it helpful, the educational part and the continuous education, the help in the match season, all of that. So, and thank you, Dr. Nader, for giving us this opportunity. If there is anyone who wanna ask question or share themselves any thought, feel free to share.
Thank you so much, Dr. Samira, and all the presenters. These are great presentations. Thank you so much. It's very helpful. Any updates or any questions for the speakers, or any thoughts, suggestions, comments? Anyone wants to share if they have any interviews or invitations so far?
Assalamu alaikum, Dr. Nader.
Alaikum salam, Dr. Rahman. Go ahead.
Actually, I have one interview, alhamdulillah.
Alhamdulillah, good.
Yeah.
You already had the interview done?
No, I scheduled it late because I started working as a medical assistant, so in order to prepare well.
Sounds good. Just
Thank
practice.
you so much for your help.
Yeah, and if you want to use the last tool that we just reviewed with Dr. Samahir, it will be very helpful.
Yeah, thank you so much.
You're welcome.
Assalamu alaikum, Dr. Nader. How are you?
Alaikum salam wa rahmatullah. Dr. Wessam, go ahead.
Alhamdulillah. Yeah, I just want to share that, Alhamdulillah, I received an invitation for an interview. And I'm so
Congratulations.
nervous, and yeah.
Yeah, just consider it as a conversation. So as long as you are interested in the program, see them as they will be interested in you. So it's kind of a two-way. It's not they put you on the spot, but you have the option to select them or select another program. So they want to impress you the same way you want to impress them. So do your best, just practice and take it easy. And I wish you all the best, both of you.
Thank you so much, Dr. Nader. Thank you so much. And I'm sure that they're going to ask us about your program and, because it's pop in everyone's ears. So thank you for this opportunity as well.
You're welcome.
Thank you
and
so much.
just practice how you want to talk about the program and how to use some of the answers to lead them to ask you more questions about if you did a project or something. So you can inject part of your answer with some examples so that they can ask you, tell us more about this, or what was your part in doing that, or something like that. So you can explain yourself better about your projects, your participation, and what you learned, and so forth.
Okay, Dr. Nader. Unfortunately, I didn't do any project. I just did 2 presentations. But
no worries. But if you want to look at the website, you can look at what other fellows did. You can talk about that as well. So what they like developed mobile applications for patients with, let's say, diabetes, patients with renal failure, renal conditions, and so forth, smoking cessation, and dental. So we have dental graduates here. So you can talk about some of these if you look at the website and have some ideas about what we already presented in the literature, like some of the projects, papers published, posters presented. So you can talk about all this. You don't have to be the one who did it, but you can talk about our group also did some of these. And if you are involved in the future, maybe you can talk about your part or the task that assigned to you. Thank you.
Okay, thank you so much.
You're welcome.
Hello, Dr. Nader.
Hello, Dr. Noura. Go ahead.
So I was asking, is there any chance that we will have an interview this late? Like if someone didn't get an interview yet?
Yeah, yeah. Sometimes what happens in these programs is that some of the mostly US graduates, they will have, let's say, 10 or more interviews, and they already decide to focus only on 5 programs, let's say. So they will send either cancellation or rejection of invitation or just exclusion about like some of the programs. So it will be some of the program will have some unplanned spots for interviews. So they will contact some of the applicants even later during the season. So don't give up hope. So hopefully you will hear something soon.
Okay, thank you, Dr. Nader.
You're welcome.
Hello, Dr. Nader. I'm gonna share my story. I actually submitted my arrest very late, as like I was not planning to apply this year. I was applying and then I'm not applying. Long story, but I applied very late, like 15th of October, to very few limited spot of programs, like handpicked for them because like the limited resources I got. I was wondering, should I wait? Should I be waiting for an interview? It's like very late for this season.
Again, you never know. The idea is if you apply to more programs, you increase your chances. But you never know. One of the program director said it takes only one interview. So just wait. If you hear anything, that would be great. If in case you don't, there is a SOAP program. So you can prepare from now on to be ready for the SOAP program. And for that, I think you need to update your application if there is a possibility for that. But at least for the interview, you can update your CV. So you can work as you did today, organizing the meeting, presenting a topic, involved in some of the research projects, like the mobile application development, for example. And this will help you if you get the interview during that time. You will also talk about it. It will be you will be unique for them.
Okay. I'm applying only for psych major. I'm interested only in psychiatry. So, but I'm trying to find some project that relates to my field of interest. Maybe a mobile application that can help psychiatric patient or physicians to deliver their care. I was thinking about
So they did develop a program about smoking cessation. That can be, if you want to work with, I think that can be translated to, let's say, Arabic, for example. You can create a team and work on the team on that. And they don't need you to show that you are working in a project that related to psych necessarily, but they want to know that you are involved in some way in some of the research and you are producing some meaningful results for helping patients.
Okay. Thank you.
Yeah, you're welcome.
Yeah, thank you.
Good. I wish you all the best, all of you.
Thank you very much,
Thank
Dr. Nader, for your support.
Thank you.
Thank you,
Thank
Dr.
you.
Nader. I'm actually on the same shoe as you because I applied late also.
Okay. Hope we get an interview and hope you get matched, inshallah.
Yeah, inshallah.
Inshallah.
Thank you all.
Thank you, Dr. Nader, for all the guidance and the help. Thank you very much.
You're welcome. Thank you so much for last minute notice and your participation. Thank you.
Absolutely.
Thank you, Dr. Nader. May Allah reward you for everything you did for us. Thank you so much.
Thank you. You're welcome. And I wish you all the best. So if no more questions, we'll see you next week. Thank you again, all the presenters, Dr. Samira and your team, and all other attendees from today. Thank you for attending, and those who will come to review the recording, thank you for coming over. And we'll see you next week. Assalamu alaikum. Have a wonderful day or night. في أمان الله.
وعليكم السلام في أمان الله.
Bye.
Bye.